Hello, everyone, and welcome. Thank you all for joining us today for our event titled Understanding Maternal Mental Health, using the updated EPDS tool and effective follow-up strategies. For your information, all participants' microphones are muted today. If you have any questions, we ask you to please use the Q&A box that is located in the bottom center of your Zoom Windows taskbar, and we'll be dealing with the questions at the end of the webinar. The chat box is also available if you have any comments or technical support questions during the presentation. And as a reminder, this webinar is being recorded. The recording will be available on the Saskatchewan Prevention Institute website and will be emailed to you in the coming days. So let's get started with the introduction. My name is Rosemary Chukwu, and I'm the Perinatal and Infant Health Program Coordinator with the Saskatchewan Prevention Institute. The Saskatchewan Prevention Institute is a provincial organization. Saskatchewan is located on treaty lands 2, 4, 5, 6, 8, and 10, and the homelands of the Métis. We acknowledge that our works are carried out on and with people from these lands. We are committed to working towards reconciliation and strive to reaffirm our relationship with one another. Our organizational focus is to help all children thrive through primary prevention and the promotion of well-being. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We provide education, training, and capacity building across a variety of areas, including early childhood mental health, fetal alcohol spectrum disorder prevention, child injury prevention, child traffic safety, parenting education, sexual and reproductive health, and perinatal and infant health. One of the focuses of the Perinatal and Infant Health Program is to provide evidence-based information on topics related to mental health before, during, and after pregnancy that is accessible to the healthcare and service providers working with parents and pregnant people and birthing parents. Maternal mental health is essential for the overall well-being of individuals during the perinatal period, impacting both their own health and that of their families. Addressing mental health needs effectively is important for supporting pregnant and postpartum individuals. Today, we will delve into common maternal mental health issues, learn about the Edinburgh Postnatal Depression Scale tool, which is the EPDS tool, its updates, and how it can be effectively used to screen for maternal mental health issues. We will also identify key steps to take after screening, including creating action plans, referring to appropriate services, and supporting birthing parents through the follow-up process. Joining us to speak on this topic today is Dr. Angela Bowen. Angela was a registered nurse and trained midwife and is a professor emeritus at the University of Saskatchewan. She has extensive clinical educator and administrator experience in women's medical and mental health. Her research focus into understanding the mental health of mothers and vulnerable women brought these areas of expertise together. Angela retired to care for her husband, but she continues to co-lead a provincial working group that has developed policy recommendations to address gaps related to maternal mental health, including designating Maternal Mental Health Day, proclaimed the first in Saskatchewan and globally, with World Maternal Mental Health Day being the first Wednesday in May. Angela was involved in projects related to Aboriginal maternal health in Australia and projects prior to retirement were to improve access to culturally secure birth in Saskatchewan. She is presently consulting to a Northern First Nation to develop a freestanding birthing center. Angela has mentored 30 graduate students. She is a prolific presenter and author of refereed articles, book chapters, and other knowledge translation activities related to maternal health. She is a proud mother and grandmother, which led to her publishing Today's Grandmother, Your Guide to the First 2 Years. Now, without further delay, let's make welcome Angela. We look forward to your presentation. Thanks.
Thank you, Rosemary. I just also want to acknowledge Alita Patterson. I believe she's going to be on the line this morning. I did offer an opportunity to talk with me, but I believe we're quite a team, and you'll see her role come up as we go along. But thank you. I am here at the Institute, which is just always been a wonderful place to be, and the work that they do. Greatly appreciate working with them over the years. So I also want to do my acknowledgements. I'm presently on Treaty 6 territory in homeland of the Métis, and I pay my respect to the First Nations and Métis ancestors of this land and reaffirm our relationships with one another. I just want to say, because I am talking about mental health and will mention suicide, that there could be triggers for you. And if you do run across these, have any sensations, feelings, please reach out to someone in your workplace, EAP, or your doctor, 811, however else you choose to get help. But don't ignore those feelings, please. So I do want to also acknowledge there was a gala on Saturday in Regina about Renee Ferguson, who took her life last year in Regina. These are her 2 children, absolutely gorgeous. And that puts the face on what we're talking about today. It literally can be anyone. So those of you who've heard me talk before, this slide has been with me a while, and 2020, we're now at 2024. They aren't saying depression is the greatest cause of premature death and disability worldwide, but they're not saying that it's not. So I'm going to leave it there. I do know that it is the #1 cause of disease burden in women, with childbearing women 15 to 44, up to 15% of immigrant women, and we have more and more of those women at risk. And it is the #1 obstetrical complication, which having practiced in this tertiary care center here in Saskatoon, we get a lot of obstetrical complications, but this is the #1 and the most under realized. This confidential inquiries into maternal deaths. The reason I go back to this is because it really was the only big study that I'm aware of that looked at all of the different databases, births, deaths, match them together. You would think that would be automatically done, but it's not. They're captured differently, measured differently, and the systems don't always talk to each other. So 12% of maternal deaths, and deaths are very rare maternally, so getting statistics is difficult. But that is during pregnancy and the first year postpartum, can be attributed to psychiatric illness. 10% of suicide, and in that study was the #1 cause of maternal death. Those with early onset illness, that's it. I've heard of women who in the postpartum immediate period, first 24 hours, become psychotic. Those women tend to die early, but most women, and you might not expect this, who die from maternal mental health issues die later, and they've been under the radar because they weren't so obviously psychotic or ill. And they die from more violent methods of suicide. So it's not a, teenage, I'm going to take some Tylenol and call my mother or boyfriend seeking attention. It really is, I'm going to hurt myself. The difficulties persist in Canada in capturing maternal deaths and maternal mental health. And I know this because one year we had two that I was aware of, two deaths by mothers within that first year, and neither of them made them to the nationals or provincial statistics. So it's something we know happens. Renee is another example of that. So perinatal mood and anxiety disorders, that title has been around a long time by the American Psychiatric Association, but it has not picked up the traction I think they expected. Often it's just called postpartum, which I don't like, because it also includes pregnancy, and postpartum really is a state of time, not a measure of mood. It encompasses depression, anxiety, post-traumatic stress disorder, bipolar disorder, psychosis, and the pinks and the baby blues. They're not disorders, but they certainly can indicate vulnerability for those women. And 20% minimal of women are considered vulnerable. The numbers appear to be going up, but the data is not readily available. Melancholia in pregnancy. That I thought I had invented when I was doing my PhD, but it really was recognized in the 1840s, maybe even before, but documented then. When I trained as a nurse in the 70s, we thought pregnancy was a time that was protective for health, that you were less likely to have a gallbladder problem or other situations in your body, but also mood, that we expected women to be happy and appreciating that they were pregnant. Very few women hospitalized unless they were psychotic. Any women who did have problems, we blamed it on their hormones. And the hormones do increase very rapidly in those first 10 weeks of pregnancy and then taper off after a while. In our study, and we had over 650 women in Saskatoon, 40% of the depressed women had suicidal thoughts in the last week. These were pregnant women. It was very scary. And highest in those who use alcohol and drugs. Alcohol is a depressant, but also people use alcohol and drugs to moderate their mood. So the DSM-4, 5 other versions of it over the years, this has not changed, is the criteria is that you have one of the first two symptoms and a number of the bottom ones. But I'm going to concentrate on the first two. Depressed mood most of the day. People will say they're depressed if they're have a physical ailment. People don't know exactly what that means when they have to describe it as a sensation necessarily, and those of their friends and relatives don't necessarily pick it up. But when I asked my husband, who was a psychiatrist for many years in mood and anxiety disorders, what's the number one, if you only had one to choose from, what would the number one symptom be? And it was anhedonia, that lack of pleasure or interest in activities, whatever they may be, going for a walk, having a bath, talking to friends, it doesn't matter. They just don't find pleasure in anything anymore. Their world is pretty empty and black. So that's where we came up with, on the posters, what do you like about being pregnant or about being a mother? And this has certainly been confirmed by women with lived experience, that this was a question if they'd been asked, they would have said nothing, which is really frightening. Weight changes don't really matter too much because women are gaining and losing weight during this time, not being able to sleep or sleeping too much. You've got a baby moving inside you, maybe a few toddlers at home, being restless, agitated, diminished energy if you're feeling tired because you are pregnant, and feeling guilt. We've been raised to think mothers are responsible for everything, and we're not. Feeling worthlessness, decreased concentration and indecisiveness. Lots of studies, that have come out and shown that postpartum, there are changes in the brain. and the world is smaller for us, so that we concentrate on our baby and our health. But those recurrent thoughts of death or suicide are never normal. So risk factors, being a female doesn't mean males don't have problems, but we're talking depression here, and women have more, especially if they have a history of depression or a history of mental illness. So I have had women say to me, well, I had no problems before, and yet were hospitalized for an eating disorder when they were a teenager, or other issues, severe anxiety, when they had to go into different situations, social phobia, couldn't get up in front of the class and talk. So there wasn't necessarily depression, but there were other mental health concerns that we tend to normalize sometimes. And discontinuation of antidepressants. Women who are pregnant tend to come off antidepressants, and I'll talk a bit more about that later. Low income, low education, because often that means low support. Single, not by choice. Age, young, older, intimate partner violence, a number of different terms for that these days, that lack of social support, particularly in postpartum women, so important. Stress often precedes a first episode of depression, particularly major depression. And for our childbearing women, this first episode is most often postpartum depression. Substance abuse, any kind of self-medication in that way, new immigrants, Aboriginal, Indigenous people, unplanned pregnancy, still, despite the availability of contraceptives, an amazing number of pregnancies, 50% still, are unplanned. So if you don't expect to be pregnant, you've just gone back to university, who knows, it can be very stressful. And having a difficult pregnancy and birth, PTSD of some form in up to 40% of women, and I'll talk a bit more about that later. Symptoms of maternal depression in particular, that anhedonia, less interest in things, crying for no reason. Yeah, I burst into tears when I walked in the house after having my first baby. There were no curtains hanging. We just moved. I thought my husband would do it while I was in the hospital, but he didn't. But continued crying after that first few weeks. Irritable, angry, more sensitive. I heard once a guy who worked for me, his wife phoned, she was postpartum, and he literally held the phone out to her. We could hear her screaming at him. I don't know how some men tolerate, or partners or family tolerate the anger, the irritability. Being tired or being hyper, always a concern, people who are hyper. Not sleeping too much. The concentration, saying that they're not going to be able to cope. And you'll see some of these coming up as we talk about the Edinburgh tool. Panicky, anxious, and again, those thoughts of not just harming themselves, but harming their baby or others. So 20% in primary care settings, that's like your doctor, nurse practitioner, midwife, can be found to have antenatal depression. It does not predict who will become, but this hasn't changed either. About 2/3 go on to have a postpartum depression. And it's a problem itself because there are effects to the baby. 24% of people in our studies and in other studies showed that pregnant people have anxiety symptoms. The pinks, I hope people are more used to this now. I introduced the term a few years ago here. It is elation in the hours and days after birth. And I know that people like to go home early, but that means you're not getting the kind of monitoring in terms of mood that a person would if they were still in the hospital. It's normal to feel good, but extremes in those emotions need to be monitored. Difficult with early discharge, and not all areas of the province have a nurse or other worker coming in those first few days, particularly if you had other children. Sleep deprivation, on-demand feeding often means that a woman will go days without having more than a few hours sleep. And when they look back at women who've had postpartum psychosis, they will often find symptoms of bipolar disorder that were previously undiagnosed. And so that is a real concern. And the expectations of pregnancy being, a trigger for some women, it wasn't what they thought it would be. The blues, yes, I had them both times. Normal, transient, emotional response. Most women recover by 2 weeks. If they're depressed, not just crying for, no reason, but having those other symptoms, they are much more likely in one study, I believe it was 17 times more likely if it continued for a few weeks to have psychosis. So this really confirms that we need increased awareness, early identification, and that timely intervention. Postpartum depression, as I said, this can be for most women in their lives, their first major depression. And if it's untreated, it can recur and potentially get worse in other pregnancies. And a lot of it is that idealization of birth and motherhood. And I've talked to women who had unexpected to them postpartum depression. And one said, why don't they teach it in prenatal classes? Well, they do. But she never thought it would happen to her and didn't even remember a whole hour of hearing about it. Hormones, yes, the hormones go up in pregnancy and they suddenly go down. If that was the cause, we would have fixed it years ago, as I remember trying in the 70s with estrogen and progesterone. And there's lots of research because there are many different types, particularly of estrogen in the body, to try and avert postpartum depressions. And if it, like I said, if it was that easy, we would just be doing it preventatively, and it's not. Thyroid, women can have problems with their thyroids in pregnancy, but also in postpartum that will actually become so severe that they have a psychosis from it. Cholesterol, high cholesterol in pregnancy that then drops. And if you remember years ago, when the statins first came out, drugs to lower cholesterol very quickly, or very low-fat diets that were popular, people not only lost their hair from that, they also tended to become quite depressed. Folate, folic acid, women are given that in their prenatal vitamins when someone doesn't have enough B12 or iron. They are much more likely to become anemic and feel depressed. And the stress. No one really knows. Even if you've had many children, every child is different, and the family dynamics change all the time. The other reason this is really important and wasn't obvious to me right away when I started this work years ago was that it can have an effect on us later in life. The hippocampus in the back of our brain shrinks. We're more likely to have cognitive decline. You know that we're more likely to have Alzheimer's and other problems. We're also, because there's an association between anxiety, depression, hypertension, and other pregnancy difficulties, we're also more likely then to have hypertension and those other problems later. Actually, some women within that same year have high triglycerides and ongoing hypertension. So it's a real concern. Anxiety, 4 to 15% of women anytime, but 25% in pregnancy, not being able to relax, fearful, phobic, tend when they do have the baby to be over concerned with them, very high parenting expectations, a lot with we started in the hospital with them, checking how many poos and pees and feeds and little spreadsheets that for some people continue and can become quite problematic in terms of their handling of their anxiety. rendering panic attacks to some, tension, hot sweats, palpitations, very scary for people. And we know that anxiety can often precede a depression, whether it's anxious in pregnancy, becoming depressed in postpartum, or even at any time, really, if it's not treated properly. Looking at Statistics Canada to see, what kind of work they've done recently. This is what I could find, not an extensive search, but should have been easy to find for us living here. 1/4 almost of mothers who recently gave birth reported feelings consistent with either postpartum depression or an anxiety disorder. Varying across the province, 16% in Saskatchewan. Well, perhaps our work has done some good, and 31% in Nova Scotia. So I really wonder about these statistics myself in talking to moms and knowing the concerns that many of you have about the people you work with. Psychosis, really scary. Scary to the mother, the family. It's still the, 1 per 1,000. We have about 5,000 deliveries in this city alone here in Saskatoon a year. And that means we should have about 5 women with psychosis. We don't reach that number. I'm hoping it's because care comes soon enough to avoid it. This lack of sleep is huge for them. Agitation, hallucinations, thinking people are trying to hurt them, hurt their babies. That self-harm, infanticide, killing their baby, homicide. They don't tend to kill partners, but anybody who might get in their way, they certainly might. As I said, bipolarity is those extreme mood swings, usually in those first few weeks, and again later, 4, 6, 8 months postpartum. Definitely associated with sleep disturbances. I'll talk more about this. PTSD, more work being done on this also. I really want to emphasize to those of you who work with childbearing people that birth and these, depression, these things are everyday events for most of us. But it is a life-altering event for clients. And someone who's had a very unexpected, in particular, long, painful labor, bad pain management. I had terrible pain management with a spinal and an epidural during my labors. And it was awful, very life-threatening to me. I was surprised when I woke up from both of them. If the anesthesia did not work, is what happened with me. And then I had emergency general anesthetic. So no explanation, you're going under. Really frightening. Hemorrhage, if the placenta is removed manually, the placenta doesn't come out for whatever reason, and usually that's associated with bleeding and concerns for the mom afterwards. If they have a vacuum or suction, we don't see many forceps, but they can be fairly horrific. Any kind of emergency C-section, she's worried about the health of her baby, herself. If there's a problem with the baby, and heads off to ultrasound workers who see an anomaly and then have to leave the room because that's a very difficult thing. And then the mothers and partners start to panic. If the baby is in NICU, as nice and friendly as they try to make it, there's all kinds of machines and beeps and all kinds of things. If they've had previous traumatic events, sexual abuse, intimate partner violence, it's hard to not be examined vaginally when you're in labor. I don't know, it could happen, but not likely in a hospital, that's for sure. So when they have a feeling powerlessness, unsupported, unsympathetic, uncared for, and I don't understand that, because to me, the baby business is the best in the world, and how a person can come out of our systems anxious to leave because they think we don't care about them is not very good. So this is an old thing. It's more than 100 years old. But it really has always spoken to me. Don't listen to old wives' tales. No shock can mark an unborn baby, because they used to think that if you shocked a baby, they would get a birthmark. My father had a stutter, and that was attributed to a neighbor scaring him. No horrible sight can deform him, but worry, fear, and anger, which all trigger very similar chemicals in our body to anxiety and depression, can affect his mother's blood, which supplies his food. Therefore, she should be calm, happy, and sweet-tempered. No pressure there. But these old biddies were onto something, because those cortisol, which is released in high stress situations, goes directly into the baby's blood. And they can have those hyper alert reactions after they're born. It can continue. So we feed good stuff to the babies, but also not so good stuff at times. So we should endeavor, yes, to keep everyone in the world calm, happy, and sweet-tempered, but trying to keep stress less for our women. And in some countries, people are sent home 32, 34 weeks to put their feet up and rest. We don't have that. And certainly in the States, those women don't even get much time off after the baby is born to feel relaxed and to feel that they have some sense of control and can manage what's going to happen. So pregnancy, these problems can cause hypertension, still a major problem in pregnancy. The placenta to come away, an abruption, they're less likely and more likely to avoid prenatal care, or less likely to participate in vitamins, those things that are considered good for them and the baby. They're more likely to end up with an epidural. Had women who come in 1 centimeter, I want my epidural now. Like there's no threshold for experiencing pain or discomfort or practicing. They're so anxious. I don't want to feel a thing. And some people choose for an operative birth for that reason. Many doctors, of course, wouldn't do that. But if you're that anxious, perhaps they would. So as I said, many different chemicals are released, dopamine being one of those feel-good hormones. APGAR scores tend to be lower, that little score they get at birth. If they're born early, which they tend to be, they are fussier, more sleep issues, less likely to be breastfed because it's more difficult to feed them, and more likely to have failure to thrive. Postpartum, that psychosis, suicide risk is there for them. And this number hasn't changed, it appears, either, that partners are about 10% likely to have it. And the worse it is for the mother, the worse it is for the partner, and a definite effect on siblings whose mother just isn't responding to them, and that's their major caregiver often for that year postpartum. Breast chest feeding, it's really, which comes first sometimes. We know that prolactin and oxytocin, which are involved in breast chest feeding, can help mood, but a sudden decrease in those because either the baby got ill, the mom got ill, she didn't like breastfeeding, or she suddenly quit for whatever reason, can plummet her mood, because these are feel-good hormones. Anxious mothers become really anxious, about 25% of them. And we normalize anxious mothers as good mothers. Oh, you really care, you're worried, those kinds of things. But as I said, counting and checking all these things can also be a symptom of OCD, and in some women can get extreme. Constantly worried and look worried. They're not smiling when you come in, and if it does, it's a strained smile. Worried about things that could happen, and I'm not a good mom. There's nothing I do right. Irritable, and that anger and rage, which can be so detrimental. So in 2009 we met. In 2010, 14 years ago, we produced The Mother First. Still get requests for it, and we do send it out online as well. Presented to the Saskatchewan government. We handed it over. Here we go. We've done all this work for you. And they turned it back and said, okay, go implement it. With not a penny, with not a carrot nor a stick. We had no influence other than talking to people and hoping they read the report. We had 4 recommendations. The first was education, to increase awareness. And materials were developed with the Prevention Institute here. They developed the logo that we continue to use. And I'll be honest, they did try to change the colors and the logo. And I kind of said, what the heck are you doing? I mean, we've been at this for a while. You know, fridge magnets were made by the wellness program. We want people to recognize it. Much effort has gone into making this awareness. Funding has come in bits and pieces from my research, from Health Canada, from the government. It's always an issue to try get funding. We've had a few mail-outs of the posters and other materials. Healthline also being educational. And there are things on the SHA and the government website. It's in the curriculum of pretty much, I hope, all health professions now, nursing, medicine, psychology. We did have psychologists involved at the beginning. We did make a DVD. It's now old, but hopefully you can access this later. So these were the materials that we produced. As I said, are you enjoying pregnancy or being the mother of a new baby? And then some of those symptoms of maternal depression are there. Old poster, I guess I used here. It should be 811 now for the Healthline. And these were info cards that were many doctors' offices. When I go somewhere else and other hospitals I've been to, I have seen the posters still, so that's great. But we need more. World Maternal Mental Health Day. I don't usually show this to the end, but as was said, this is now a global event. Postpartum Support International had staff to support this. And so they have taken it over, and I'm very glad for what they have done. I think one year it was over 40 countries participated, and lots of events. You know, they'll have a day to celebrate, or some places have turned it into a week. Alita and I continue to ask the province for recognition for this as Maternal Mental Health Day, as we've done since 2013, to keep their awareness, and hoping, honestly, that if they support us this way, they'll continue to support us. Recommendation number 2, universal screening. We wanted to normalize, as did the women we were working with, that we care about all aspects of your health, not just physical, mental. The one tool that's been available since the 1980s, but is still valid and has been tested. And if someone finds a study that shows it's not valid, please send it to me. It was developed by a psychiatrist and a psychologist who herself had experienced severe postpartum depression. In our recommendations, twice in pregnancy, at the first visit for it to be administered, because we know there are issues that can be created for the mom and the babe throughout pregnancy. So let's pick it up right away, try get treatment. And 28 to 34 weeks, because one of the things that happens is actually the blood volume increases, and the effectiveness of antidepressants or other meds can often decrease. So as this woman walks into this time in her life, postpartum, the highest risk for psychosis, we want her to be most stable and most ready for this time period, not less ready. The Edinburgh is now also associated with the prenatal sheet, and is on there. That took a few years, and a promise on Maternal Mental Health Day from one of the various ministers of health over the years. 3 times in postpartum, for those programs who have an early discharge program, which often women are discharged 2 to 3 weeks. I think that has changed depending on the program. You may just get a phone call. but certainly within public health. And during those child health checks, still called by many immunization checks at 4 months, if not at 2, and at 6 months postpartum. And I must say the public health nurses and in those first few years we worked on this, were really eager to take up this and very pleased with how they approached it and owned it in many ways. It didn't stop obstetricians who had been using it for a while. They'd heard me talk for years from doing it at 6 weeks, but we don't want to wait till 6 weeks to find out there's a problem. We want to do it much sooner. So the EPDS, it says postnatal depression because that's what they focused on, but it has been researched by myself and others in pregnancy, really in anyone who may have physical symptoms that may cloud depression. So someone who's had cancer, where their weight and their diet and their concentration, all of these things, sleep may be affected. So it's been tested in many people, including partners. So you're screening, not diagnosing. Screening for the probability of depression. It reflects your mood over the last 7 days. Does not diagnose, can't say that often enough. We don't want women walking away saying, the nurse diagnosed me with depression, likely to plummet them further. We want them to be referred to someone. And the anxiety subscale, which I'll talk about, which we did here in Saskatchewan, the initial actually affirmation of this in many women. It's short, 10 items, doesn't take long. Self-reporting, very important. Free to use. There's other tools out there, yes, but they cost money every time you use them. And we knew walking into this that having a tool that might cost $3 or $4 each time, the government was not going to fall for that, even if I could use it in research. It was never going to happen on a practical level. It is easy to do. It is easy to score. Been validated so many populations and languages, including Indigenous women in Regina, postpartum women. So that's good. Picks up anxiety, and it's a rapid identification of suicidal ideation. And it can and should be used with the partner sometimes. What we did as we made revisions to the tool over time was add an alcohol and a violence abuse, intimate partner violence component to the EPDS, because it is known that these 3 things go together: maternal mental health problems, depression, anxiety, alcohol, violence. One psychiatrist called them the golden trio at one point. So we added them to the tool. And the physicians, there was a midwife, family physicians, obstetricians, all of those people who were on the committee at a provincial level, as we put this on the prenatal sheet, had absolutely no problem identifying the interrelationship with this. And we had no comeback on it. It seems to provide some caregivers issues in administering the tool. So hopefully we'll have time at the end that you can ask me anything that you might not pick up from today. So the anxiety subscale of those 10 is what we've highlighted on the tool, 3, 4, and 5. And that is because in pregnancy, these are the predominant symptoms. 1, 2, and 8 are the ones that are predominant for only depression, but the tool overall works best together. But if you're working with a pregnant population, perhaps looking at that, those 3 can be helpful to you. We added the woman abuse screening tool, 2 because it's been taken down, validated to 2 questions. Asking someone if they've been abused or are being abused. You don't get the right answer right away. I was involved with our interval house here for years. I had an eye infection in Ottawa once. And I mean, I'm almost 70. This was not that long ago. And I went in and in the emergency room for my eye, which was bleeding. Are you being abused? And whoa, like it just blew me away. But research has also shown you need to ask that question 7 times, even in a hospital setting, to perhaps get a response that's positive. And certainly never in front of other people or partners or translators. But this question is a good proxy. 2 questions. In general, how would you describe your relationship? A lot of tension, some tension, no tension. And on some days it might be, a whole lot of different things. Do you and your partner work out arguments with great difficulty? They can't come to resolution on things. So frustration builds up, lots of things happening, or no difficulty. So if a person answered question 1 with a lot of tension and with great difficulty, discuss it with them. Make sure you follow up. It could indicate why they are depressed. The TACE, because it had been validated in pregnant and postpartum women, I know that there's CAGE, there's other ones out there. We had women who answered this in pregnancy and again in postpartum. We also asked them a retrospective question, and they didn't even necessarily answer this correctly in pregnancy. When they knew they were out of the pregnancy and that their baby wasn't going to be taken away, they did admit to more alcohol and substance use during the pregnancy. Sorry. Oh, there. Oops. Okay, sorry about that. So the tool is very self-explanatory. How many drinks does it take to get you high because of that tolerance that can be built up? Have people been annoyed or criticizing you because of the drinking? Have you felt you should cut down? Have you had a drink in the morning to steady your nerves or to get rid of a hangover? And if someone scores 2 or more on this, it indicates a problem for potential perinatal risks. Remember, these are women who are pregnant. Chest breastfeeding flows right through into the breast milk with no problem. So it is something that should be discussed. We wrote a paper years ago on, a drink is not necessarily a drink anymore. They're huge, supersized like everything else. And also that some women in some populations can be ridiculed if they try to cut back on their drinks. It can be very difficult for them to not succumb to peer pressure actually in their lives. But it's a really worthwhile tool. We did a study with, really quite high income affluent women, and I was shocked that 30% of them were drinking daily within that first month postpartum. Oh, I didn't drink in pregnancy, so I'm going to drink now. And they were all breastfeeding and didn't think about, should I, maybe if I'm going to drink, do it right after I breastfeed, or pump out that breast milk because I was drinking and dump it and store some in the freezer so you can take it out at such times. No thoughts at all on that. So the abuse. I'm just summarizing here. You're asking for support with injury, personal safety, and it is a real issue. Abuse, physical abuse, can start or get much worse in pregnancy for whatever reason. It's been studied. Threat, jealousy, you name it. But the face, the abdomen, where the baby is living, are actual targets. And I've certainly seen women with bruises on their arms, heel marks on their pregnant belly, abdomen. So it's a problem. There are safe houses, certainly always 911, but the safe houses in this country are connected and women can be moved to other sites. So the TACE, I have talked about it, that risk for perinatal is 2. They need to be further assessed. And here in Saskatoon, a woman who's drinking or using drugs is fast-tracked into facility to help her become abstinent during that time. And not always easy if you've been using that for self care over your lifetime. This has not changed much in the years that we've done it, so that people can, caregivers, you can always turn it over, you can download it. It's available through SaskHealth, but I'm hoping it's still available here through the Prevention Institute. And with particular scores, what might be done by practitioners. I won't go through it word by word, but also some support there for self-harm questions. So didn't know how hard it would be to write on something until I tried to get it straight. But there was requests, and worked on this for a group I'm working with, but also for some other people out there, that you can give to women, help you describe how to do it. Usually if you give someone a clipboard, you can have this on the front, how to finish this, excuse me, and underline it, check it, exit, however you want them to do. And they can turn it over afterwards and give it back. And to make sure they know that if there's a question that upsets them, they don't understand it, to please talk to their care provider. So sometimes the people will say, thought of harming myself. Well, you know, I don't hear so much about cutters anymore, but, you know, yes, that would count, because even though they may not be suicidal, they're self-harming at a very high level, and things are not going well for them. That ability to cope, some people question that. Where's that one? Oh, sorry. Look forward to enjoyment. That's, you know, those first two are really connected with that anhedonia. Things getting on top of me. So that's the one that addresses, the ability to cope. And that's a really good one. You know, you go into a house that, you know, there's a new mom and it's spotless. Knew you were coming, so maybe cleaned up. Or it's, you know, you can't find a thing, you can't sit down. Either one of those would be a bit of a concern for me, because how is she coping? Is she focusing on just the house? Is she so overwhelmed that she can't do anything? So interpreting these things, this was developed in Britain, so they may, you know, have a different way of wording things. But if they don't understand, I think you can help them through that quite readily. Again, a screen is a screen is a screen. Don't ignore your intuition. If she's your intuition, your gut feelings, if she's not looking at you in the eye when you talk to her, when you ask her if she's enjoying this time in her life, and she does not interact with you, big red flag. What you see, what you feel, what you know about her, the Smiling Mask Women, which Lolita is part of, their book, their video, they, you know, you can smile through just about everything, but there's strained smiles, as I said. The Maternal Wellness Hotline, 811, for referrals from public health nurses. We have been trying for years to change this for postpartum women, but women can also connect directly. The public health nurses can phone in and do that referral, but that's in postpartum. So there's been lots of concern we've had, and of course, always emergency. So say someone answers 0 to all of them, but seems depressed. Well, clearly they're not being honest, right? They just 0, 0, 0. And I've seen women, maybe they're borderline personality, just want to mess with you. Or someone who scores high on the first 9 questions of the 10, but then does not answer number 10. That's the one about, have you thought of harming yourself? And here we added in one program, although it doesn't contribute to the score, have you thought of harming your baby? It's a next logical question. High level of trust needed for that. And they are then either scared of answering, worried about you taking their baby, worried about family knowing how they feel, so embarrassed, who knows. But it's not something to ignore, and we didn't ignore it. Even in research, we would reach out to people. Given that things are so difficult for you right now, it'd be surprising if you didn't have the occasional thought of not wanting to be here, which is a nice way of saying taking yourself out of this world. Are you feeling so angry that you might be afraid of harming your baby? We're here to help you. So even if you aren't a mental health specialist, you can help women through this time. Do not leave a positive number 10 alone. There's suicide risk. And ask them, do they have thoughts of harming their baby? So increased risk 17-fold of suicide. They're going to do it. This is the time in their lives that they're most likely, especially in the presence of a clinical disorder like bipolar disorder. Follow up on all positive responses, even non-positive. If there's a really high score and they don't score to that, just wanting to check in, any thoughts of harming yourself or your baby, you can add. If you say it in a gentle, kind, thoughtful way, that should not cause hackles to come up, even with an angry person, although it might. So the score may point to depression. So they have, say, 11 or 12, but may not identify themselves that they are anxious or depressed. So are they sleeping, eating, repeating things, say they're stressed? Ask them what they're worried about. What are you worried about? Oh, the baby's weight. My husband doesn't come home anymore. Anything. Are you enjoying being pregnant or a new mother? Avoid judgment. Get them support. One of the sad things I learned was that although you'd expect women's mothers to be the most supportive, if they didn't experience this themselves, they're more likely to say, oh, you've got a good, husband, go for a walk, eat more, let me take that baby from you. I've heard that more than once. And then not giving them the support or acknowledgement even that is a difficult time or what the person may be going through. So if you're concerned about that last score, refer for assessment, treatment, the maternal mental health program that you might have in your city, if you have one, maternal wellness at 811, the emergency, or we do now have a national suicide hotline, 24/7, says on it that you don't need to be suicidal, but that might be something if you're going to leave someone, and I don't wish you wouldn't, but if you have to for whatever reason, or they won't let you take them to the ER, no one's going to be with them for a while, then 988 would be an option for them to get support. It's interesting to note that Andrea Yates, who years ago killed her 5 children, convinced her husband to go to work. She was a nurse, by the way, because she was going to be fine. The mother-in-law, she was never to be left alone. She'd been hospitalized. Never to be left alone. I'm okay. The mother-in-law was coming a bit late that day, and when she came, 5 babies were dead. 5 children, including a very young baby. So don't leave them alone. There's lots of ways that you could call someone else to come and try and convince them to come with you or go to the ER. Our third recommendation was to prioritize maternal mental health and mental health services. Well, I'd like to say we succeeded. We contributed to various reports over the years, including immediately after I'd had my rotator cuff surgery done, presented in front of one of the various commissions there have been. And I don't believe things have changed enough to make a difference. We wanted things accessible in each region when there was regions. Very hopeful we were that when SHA is a big umbrella organization, that this would be picked up better. Disappointed. and increase the options, cultural, geographical. And for those who can't afford, which I imagine now is just under $200 for a private psychologist. Coding of maternal mental health, as I said, it's not necessarily picked up if you're pregnant and you're anxious. If you're postpartum and you're anxious, all of those things are not necessarily there. And accountability of the system. And that's where I truly credit my partner in crime, Alita Patterson, who has made friends or enemies with every secretary of every minister of health and minister of mental health and addictions, who we have met with every single one since 2009. It is absolutely remarkable. Thank you, Alita, especially considering her daughter is now at university. Helping, how can you help if you don't have other resources? Affirmations, simply saying nice things to people, listening visits, they're sometimes called, can help build upon their strengths when they're feeling that they have nothing going for them. They're feeling helpless, hopeless. Even just saying how the baby is watching you. And I was thinking about it last night, pleasant memories of this woman years ago when my son, so this was in the 70s, walking down the street with my best friend and my son. And she said, I can tell he's your baby because how you look at him. And it still warms my heart 45 years later. It is just a slice of a moment that can help them. Look how you hold him. It's so caringly. You're a wonderful mother. Those kind of things promote positive mental health, but also for that split second may give hope. Helps self-esteem, walks. Yes, grandma might say, oh, just go out for a walk. But it really can help. Walking groups, stroller groups, putting babies in slings. Lots of research now on forest bathing. That's me and my dog, forest bathing, and being out in nature. I know some communities in the north, maybe south, it is not safe to have a stroller group, too many dogs. But they're often school gyms, anything to get women together for the social support, but also some exercise, yoga, you name it, it's all going to work. Trying to get 6 hours of sleep in 24. Now you say, oh, that isn't much. But if you're waking up every 2 or 3 hours, takes you got to pee, you got to change the baby, feed the baby, get back to sleep. And then, you're aware that, oh, someone else is getting up or doing something. Very disruptive sleep. And you have to be a very healthy individual to withstand that. Nutrition. Yeah, little sleepers are cute, but now you can even subscribe to food things for people, take things to eat. There used to be, I don't know if it still exists, a church group in Regina who did that for 6 weeks. Grandmother Kukum groups, they often know, how can I interact? Well, food is a great way. And we have the Canada Prenatal Nutrition Program in this country who use food to reach women, not just about nutrition, but all aspects of their life, to have a healthy pregnancy and a healthy postpartum. Simplifying their life. Do they need to be doing so many things? Likely not. And being on their phone, maybe turning it off for a few hours while they lay their heads down. Massage, also good. Meds, we really promote preconceptual counseling. If there's any way that a woman is planning to meet with her care provider and talk about if they want to come off their meds, do it before you are, those women who are on psychotropic medications, do it before you become pregnant. And be stable for 3 months is the usual advice. Then perhaps go into a pregnancy. When women come off at 5 or 6 weeks or sooner, in all honesty, if there was going to be a malformation created, no research that has stood the test of time on that, it would have happened. Those anomalies happened quite early in pregnancies. The one exception to that we know about are the mood stabilizing drug, valproate, Elavil, some of those drugs are much more likely to cause spina bifida, those kind of problems. So what is recommended is to be on folic acid before they become pregnant, and to make sure they maintain a high dose throughout pregnancy to try and avoid that. And those drugs are mood stabilizing drugs are also used by epileptic women who are now going into pregnancies more than they did in the past. If a woman comes off the drugs during her pregnancy, it can be extremely hard to stabilize her mood as the pregnancy continues. We do have a Saskatchewan drug information line for care providers and the public that is through the University of Saskatchewan. And we have to support quitting. We can't just say quit. If someone has been using these issues for self-medication for years, very difficult just to quit. And they'll lie to you otherwise if you don't know. And studies of hair samples in pregnant women who said they had quit showed that they didn't often quit. But they can be given Wellbutrin, a patch to help them, and giving them as much support as possible. This is the Canadian Psychiatric Journal and their lines of treatment for people, cognitive, behavioral, or interpersonal. Either one, we did a study with pregnant, anxious women. It worked with either one, and then the different levels of support there are. This was done, I believe, in the 90s, but there's new guidelines due the end of this year. I thought they might already be out, but they aren't yet. So that'll be good, because that's what family physicians, psychiatrists, other care providers can look at. But the first line is always, I'm sure, going to be a non-medicinal approach. So I talked about the group support listening visits, shown to be very effective, not just educating people, not just telling people, but having a therapeutic approach within there. CBT coming out in the most recent research I looked at as the most effective. We are fortunate to have at the University of Regina the online therapy user group, well-being program. We had years ago a postpartum component of that, and it was validated very effective. The women can do it at home by themselves, which was pre-COVID, and now would be, I'm sure, much more acceptable to people. COVID happened and was harmful to the ongoing in-person support programs. So we have to look at other ways now. And to have that geographic availability across the province, we need to know that if you're in a small community, it's not always safe for someone to go into a group setting and talk about their worst fears and how they're feeling, even though people can sign agreements not to disclose, they don't always follow through. Light therapy, very effective, that's used for seasonal affective disorder. Exercise, nutrition, very important. The neurostimulation some of the psychiatrists are doing on the brain. I don't know how active it is throughout the province, but certainly here in Saskatoon it is. And the government does fund it now, so it's really good. Right to the brain. It's not like a electroconvulsive therapy. And it has been shown to have good effect on mood, no adverse effects to the pregnancy. So that's really good. The most important thing to remember is, although we may start out with one, it's pretty much always a combination, depending on the severity of the problem, of approaches for that person, including medications, as I said. What else is happening out there in the world, the country? Other jurisdictions, Toronto, Vancouver, been doing this for years, will allow moms who had a previous history of postpartum depression, psychosis, or anxiety severe in pregnancy, or who had been on mental health supports for a long time, to stay in the hospital 5 days, not asked if they're comfortable leaving at 6 hours. They sleep while the baby is being cared for in a nursery. We don't have a nursery anymore. And their mood and their meds are managed before their discharge. A lot of physiological change, as you well know, from the day before the baby's born until someone is discharged from a program. So they need to be looked at. Other countries have these mother baby units. I was fortunate to go to some in Australia. They've been there for years. They can have inpatient and day programs, beds for partners to stay over, cribs. It's really fabulous, but they are also locked units. They're safe, and they still have had people leave, but and hurt themselves, unfortunately. Intensive support and therapy is the focus. Everything they do has a therapeutic value to it. So for those of you who may not be in professions that allow you to do care yourselves, and I think of some of the peer supporters and other workers out there, birth support workers, that we made with the help of the Battlefords, this maternal mental health toolkit. So it looks as the back of the other toolkit, the EPDS tool. And we developed 13, two of these suggested by mothers afterwards when we were testing them, one-page handouts that can be used to start a conversation, continue a conversation, and know where people are at. So what they did up there, they'd have them all in their kit that they were using to go into the house. Women could pull out, it might be a breast or boundaries, and then they would discuss whatever was on that. Women put them on their fridge. These have been asked to be used across Canada by various groups. Very happy to do it. And again, thank you to North Battleford, Kathy Beale, and her group, really positive. This is for Indigenous people. This went literally off the air. Couldn't get it for a few years. But I would see there's some tools in there that anybody could use, but certainly for people who are working with First Nations, Métis populations, this is a workbook that people can go through as a group or together, individually, I mean. So in Regina now, there is the Regina Perinatal Health Network. They had a fundraiser on Saturday. I don't want to say it was entirely for Renee, but I know that she was the focus of this. What do? They do provide support, education, support groups, and postpartum wellness services. So a whole lot going on, working with other groups in the area, in that geographical area. So, a lot of people coming together to make this happen, and hopefully we'll receive funding as years go by. Saskatoon, this one's been there a while. It changes over time. I can't say what it is today, but there's been at least 2 psychiatrists for the last few years who are available. Nurse coordinator, I was a therapist at one time, and the amount of time that person is available has changed depending on budgets. Support to GPs. So what this group does is they will send back a report after they see a woman, usually no more than 3 times, the psychiatrist. And that will give very intensive directions for how to treat this woman. So if you're a GP or a resident and you see this over, you're going to get more comfortable prescribing meds or doing other things. So we did have an advisory group out of there, but I'm gone and it's gone. The postpartum depression support group, now virtual, and there is the breastfeeding center and supports, and they have a I can't remember what it's called now. It was called a cafe, and moms could come and they would talk about mood and other things. So it was all interconnected. This is what I got off their page recently. They were supporting the province, but they cut back on that. Not sure why. But the nice thing is they do have specialist psychiatrists who are available, but you can only see these psychiatrists by a physician referral. Most people, it appears, continue to talk to their GP if they have mental health problems. We have the maternal wellness line, as I said, by referral or directly 811, the suicide hotline, and 988, and this online therapy group. Under development now, and Alita and I are both involved with this, is a well-being course through this online therapy group, which is well-researched, well-funded in many ways, and amazingly given money by our government to support this research program. So it will be, the hope says it will be a program over the next 2 years. So that's really exciting and glad to see. The Canadian Perinatal Mental Health Collaboration. We didn't use the word perinatal because not everybody knows what that means, but I know maternal is offensive to some people. We've kept what we have, as most places have. They have a walk every year, and they too had a signature woman who sparked, and has helped them. Although they were a group of moms who came together before, and I was involved early on. This mom, Flora, who took her life, which isn't this terrible that we need people to take their lives to get this kind of action. They have walks every year. This year they raised over $200,000, and we did have a walk here in Saskatoon. I was happy to be invited to that. And it was a beautiful day. What can I say? I hope that we had some impact. They're hoping to get chapters across Canada. We do have a Saskatchewan, I should say, chapter, but they haven't listed it because the other ones aren't available. I don't understand that. They do have a list of care providers, but they are not evaluated. So to me, that's a bit risky, and we've never done that. We've listed programs that are offered by different people, but not individual practitioners. So this is a Facebook group, Mother, see it there, Mom, may I think it's called, sorry. Again, they have care providers, but again, not evaluated as such. They advertise Maternal Suicide Awareness Week, which is odd to me. It wouldn't occur during maternal mental health times. And they have a Facebook group, and we're offering virtual perinatal mental health peer support. So that is great. And 6:30 to 8:30, there's no time that's perfect for anybody. There just isn't. But if someone knows, and hopefully they can go somewhere else, leave their home, even in their car, I don't know, or have someone come into their house, babysit for a few hours. I think this is the kind of thing that we've been hoping would happen. And so it is there. So things are happening. So wonderful to see. And they do have that connection with the national organization. So our last recommendation, maternal mental health committees, it's not happening anymore. SHA, I said we were hopeful. They did request an environmental scan. We got some public health students to do that for them, master's students. What it showed was the most knowledgeable about maternal mental health and the resources were public health nurses. The least knowledgeable about any of this were mental health service providers. Yet they are the ones who are providing often that one-on-one service to people who are really suffering, and they feel undertrained. We've had ongoing negotiations, as I said, Lolita and I, inviting other people, posting pictures of it. I can't tell you how many times the next budget will have what we need, and it just doesn't. So we continue reaching out to them. We're told in the next budget there will be something we'll be happy about, and I hope that we are. So that's my little grandson. And And any questions, I'm sorry I didn't leave a lot of time. You can always, of course, email me. So I guess I can look at the questions, or how do you want to do it, Rosemary?
Yeah, I'll just jump in here and say thank you, Dr. Angela, for your very informative presentation and sharing your knowledge with us today. We have lots of questions. And like you said, due to time constraints, we won't be able to answer all of them. And we can compile the unanswered questions and email the responses to the audience along with the webinar recordings. Okay, so.
Should I just read them from the top?
Oh, yes.
Okay, so the question I'm looking at is, what are your thoughts about the translated versions of the EPDS in Australia? They have not been validated in Saskatchewan. Better to have a conversation. Also, languages not represented. Yeah, for sure. I mean, the number of dialects, we thought, I mean, I had a lot of people keen to do a Cree version, test it, get it validated. But you know what? I go to different communities. The word kukum is spelled probably 4 or 5 different ways, even a simple word like that. So getting a translation, to do a translation is very cumbersome. You have to have it translated and then back translated. And in the book that the EPDS comes in, and it's a very helpful book, they have many translations at the back. So when I first started this work, I had a Chinese friend from China, and I gave her the Chinese translation to back translate. She had no idea what I was doing it for. Can you please translate this for me? It takes a lot of time to translate things, and money normally. And it was pretty good, but it wasn't exact. It never is. I mean, it's not an easy process to get all these various translations. Well, I was in Australia many times because of maternal mental health in Western Australia. They have done one with little faces on it. It was still being validated, and it's been years in the going. So it's not something I avoided. It just wasn't something I felt would be successful. And even people in Canada, I've lived from Vancouver Island to Prince Edward Island. People pronounce, say, acknowledge different words. I'm from Britain, like a different language sometimes. So not that I didn't want to, or that other people haven't wanted to, but it will be very difficult. The revisions to this version, as I said, is we added the woman abuse screening tool too, and we added the taste to pick up those things that are very associated with maternal mental health problems. Any discussions of making the language more inclusive, as I've said, and I didn't update all the words in this. I probably should have. As part of making the guidelines for the Ontario Registered Nurses Association years ago, and we did work very hard to make it be person, people, etc. It's very difficult. It is very difficult, and it's we have not. I mean, anybody who wants to inherit all this and go for it, I'm retired, go for it, make it that. But there's a good chance people are going to go, what is perinatal mental health? And the majority, I am the minority in many parts of my worlds, are maternal. I mean, it's that simple. And we have done a lot of marketing, but not acknowledging it. So the EPDS is in other languages. Oh my goodness, I did have a student work on this. I would have to see, you can reach out to me, but it is, if you buy the little EPDS book, it's not a big book, not expensive, the most recent versions. It has in the back many of the languages. And you can go online, as other countries do it, they will often, if you have a particular language, they can often do that. They would give you their version that they have validated. And if it hasn't been validated with that back translation, with different members of that population, hard to tell. If you can get someone in a family to validate or in a church group or something, then that would be great. But we always have to be careful with whoever is translating that they're not too connected to that person, because they won't answer. They'll be very afraid to. We did translate it into Arabic. I had a graduate student who was a doctor, and she translated along with a few other things, and we tested it with a group of refugee women out at West Winds. And so I still should have that, but I did compile them all into one document a few years ago that was a little easier to read. So can you get it? I don't understand this question, especially from nurses who have 4 years of education that includes intimate partner violence, includes alcohol in their mental health teachings. And I'm sorry to sound frustrating, but I really don't understand this. I just explained to you that it is a simple tool. Those are 2 easy questions. Do you not want to know if the person's feeling that they have a lot of tension in their lives for whatever reason, or alcohol? You make a referral, as you would if you were on a medical ward and you had a drunk or someone who continued to ooze post-operatively because they're drinking all the time, that they don't get well. I just don't understand it. Why this has caused you to be vulnerable to discussing all topics effectively. What wouldn't you be able to discuss as a nurse or a peer supporter if that topic came up years ago? I simply don't understand that. I hope I've answered that for you today, but who knows? Using phoning 811, option 2 for mental health, yes. That's what exactly you should do. And they did that years ago with our support, because that's going to be a psych nurse or a social worker or someone with a lot of experience in that area. Often they will screen a mom who calls in about some other physical problem, maybe with the child or themselves on that other line. They will screen with the EPDS. So yeah, go for it. Most of the time they circle the score. Could this be affecting their score? You know, I guess it could be. The problem is, if you want to do this really quick, and it has been tested and it's been shown over time not to really affect the score, because the score alters in which way it's done within the tool. There's an actual name for that. I can't remember what it is, but it doesn't seem to make a difference, honestly. You could take it off if you wanted to, but it's going to be harder for you to. And we did take it off in one research, but we put it back on. It honestly didn't make a difference. And again, if they're scoring low and you see something different in their behavior, then disregard and just go for it.
The rest of the questions that are answered to be sent through email with the recording. Thank you so much, Dr. Angela, for this presentation and sharing your knowledge today. We can all agree that we'll be able to apply the knowledge and information we gained today to our individual fields. Thank you all to the audience as well. When you close the window, you will be directed to a link where you can complete a short survey evaluation of this session. Completing these evaluations help us create programming and resources that support you in your work, and we appreciate the time it takes to complete them. Thank you all for joining, and have a wonderful rest of your day. Thank you.
Thank you so much. Take care, please.